Thank you very much, Dr. Marlus Farang. Can you share your slide?
Yes, he has already shared.
Okay. He is really outstanding performer, especially left-hand bifurcation. He visited several times in Bangladesh, and he also worked in NICBD with our Secretary General, Dr. Professor Mir Jamaluddin, along with Mir Jamaluddin. I think he is the now he give his talk when one stand is not enough. EBC main study perspective.
So, dear colleagues, thank you for the invitation. It's really great pleasure to be part of your meeting, and I believe, yeah, it's online meeting, but maybe next year we could have face-to-face meeting. So we have now one more study which I would like to present now, and maybe to give you bit more answer what to do in simple distal left main stenosis. And as Professor Taggart mentioned already, we have a very clear European guidelines message, and so our clinical director, Professor Neumann from this center was primary author of guidelines. So as you can see, if we just take into account patients with left main stenosis, so there is a green light if we have in general syntax score below 22. So you can go with CABG, but you have a green light to go with PCI. In intermediate syntax score, there is a green light for CABG. You could go with PCI, but it's not really first line. And similar suggestion to patients with high syntax score, CABG is the first line therapy, and you shouldn't go primary with PCI except patient is not suitable for to go to the operation room to be operated. As you mentioned before, Dr. Shaivan, we have distal left main stenosis we will find in nearly 80% of cases, and this is the problem for interventional cardiology, because then we have to usually go ahead with a complex approach. And I think important in this setting is also to know how is usually the plaque distribution. And the plaque distribution, we know this from many IVUS and OCT studies. The plaques are going mainly in 90% of cases from distal left main to the LAD. And this is explanation for the fact that we usually stent primary left main to LAD. This is the first way for stenting. And left main plaque distribution from left main to circ is in around 2/3 of cases. And another important point is we have in more than 75% of cases to manage distal left main stenosis with a diameter something between 4.0 and 5.75. And definitely imaging is strongly recommended. And of course, we discussed this point in previous lecture, but of course, in general, you have practically all these 3 options or 4 options. We have provisional approach, we have tap and culotte, which are suitable for both approaches. You can go primary with double stenting, or you can use both approaches as a bailout. And definitely there is a part of patients which need definitely primary stenting of the side branch, and then you can go here very easy with Dickey Crush. But this approach is technically most challenging point. Just to go forward, we have, of course, Dr. Chen will go in details to both studies. We know from Dickey Crush 3 trial, there is a significant benefit for Dickey Crush, And there is, again, from Dickey Crush 5 study, comparing Dickey Crush and provisional T-stenting, again, a clear benefit for Dickey Crush. There's in provisional stenting, there is some increase of events in first few days. In Dickey Crush, there is a really stable curve ending here by 5%. Till now, and this is the statement from European Bifurcation Club, so we should go with, try to go simple to the distal left main bifurcation, try to use one stent, final kissing and final pot are practically obligatory. And according to this approach, we had information from a registry on studies. You can you need only double stenting in something between 20 to 40%. In our center, which is high volume center with more than 3,000 PCIs a year, we have a number of 36% double stenting. And of course, you have to go with 7 French better than 6, but 6 is possible. You need a perfect lesion preparation. You can use, at least in Europe, IVL and orbital atherectomy or rotablation, and especially if you have primary complex anatomy, as Dr. Scheiben showed in his final slide, then you can go primary with Dickey Crush. And of course, post-dilatation is extremely important. And I'm really happy to present you the results from EBC MAIN study. So we were one of the top enrollers centers, and it's really my privilege to share the data with you. The study was primarily presented from Dr. David Hildig-Smith during this year Europe PCI meeting, and the background was clear. We have a lot of randomized studies not supporting systematic double stenting, and even in larger bifurcations, according to the data from EBC II trial. And we have even some signals that maybe systematic two-stent approach is associated with increased mortality. And left main bifurcation lesions are a bit different. We have to manage large vessel diameters. We have larger, wider bifurcation angle, and so the two-stent, the idea was, or hypothesis was, two-stent approach will be expected to be worse compared to single stenting. But however, we have a wonderful and very positive data from Dr. Chen from China, supporting definitely Dickey Crush in this left main bifurcation. But let's see what this European study show now. We have here randomization with stable or unstable angina with Medina 111 or 011 in patients requiring PCI. And all patients, this is all patient subset with unprotected PCI, so CABG was exclusion. And we have 230 patients with single stent, 237 patients with double stenting. And I think also important information, only a resolute onyx stent was used in this study subset. Primary study endpoint composite of all-cause death, MI, and target lesion revascularization at 1 year. Few secondary endpoints, including also the rate of success and procedure duration and X-ray dose, etc. And here just one word to resolute onyx, why we used this stent for our study. Yeah, first of all, there's a stent which can be postulated up to 6 millimeters. So there is practically every human left main will be covered really without malapposition using this stent. There is minimal shortening, and there's, due to open cell anatomy, a very good side branch access. So this we had here few benefits using this stent. And technical approaches are simple provisional approach, step by step, pod and keys mandated. And according to the systematic double stenting use, it was led by operator choice, which double stent approach will be used. So majority people could use step, culotte, or dickey crush. Of course, keys and final pod were mandated. As we can see, our patients now are going to be older and older now. Average age over 70 years, and diabetes patients around 30%. And I also would like to mention this information here, acute presentation. I mean, it was unstable or non-STEMI, acute coronary syndrome. Patients were in 1/3 of patients. So syntax score, 23, around 23 in both study arms. Radial approach in 70%, and 6 French sheath in 60%. So as you can see, and I was really surprised, because we recommend to do pod, we recommend to do kissing and final pod, etc. But you can see we have to be really critical. There was no 100% according to the complete study population. So I was personally really disappointed according to this point. But one important message was from this slide here, you have to take with you, there was a crossover allowed, of course, and this crossover was 22%. So in around 80% patients in provisional study arm could be managed by using one stent. So, and if we go to the double stenting group, so which technical approaches were used, and as you can see here, in more than 50% of cases, culotte was used, and in more than 30%, TAP or T-stenting was used. And dickey crush, it's not really very popular in Europe, was used only in 5% of the study population. And in a stepwise approach, if there was a need to stent the side branch, so in majority of cases, culotte or TAP were used. This is a primary study endpoint, death, MI, all-cause death, MI, target lesion revascularization, 14.7% versus 17.7%, not significant difference. And even if we take a look to the secondary endpoint, death, MI, TLR, stent thrombosis, no significant difference. Was surprised 6% TLR for single stenting and 9% for double stenting. So if we see this slide now as other presentation as a graphic form, you see 15 versus 18, and MIs similar in both groups, 10% per procedural MIs, death 3 versus 4%. So in conclusion, this study could demonstrate that using, if you implant onyx stent in distal left main, so you could achieve a good results at least for 1 year. We had numerically fewer serious adverse events with the provisional approach. Other hands, procedure time, X-ray dose, and consumables were less or more in double stenting. So let's say we can, in summary, say at least a huge part of patients with distal left main stenosis who are not really good candidate for surgery with low syntax score, they will be a benefit from provisional approach. And if we just compare ABC MAIN versus Dickey Crush 5 study, you see very similar points, a similar number of patients. We have 11 countries from Europe. We have 26 countries from Asia. Syntax score definitely lower in ABC MAIN study, quite high in Dickey Crush 5 study. And as Professor Scheiben mentioned, we had here side branch length, which was usually circ, was 7 millimeter versus 16 millimeters. Crossover 22%, and in Dickey Crush 5, 45%. And I think also an interesting point is, despite the recommendation to use imaging in distal left main PCI, only 40% of patients were had guided PCI, IVUS guided PCI. And similar endpoints here, we have death MI, TLR. Here we have cardiac death, target vessel MI, and TLR. But there was a clear difference here in 1 year results. And in ABC MAIN study, there was no significant difference between single versus double stenting. And you see, it was a 5%, 5% in double stenting. So from our study, BBK II trial, we had also included 50 left mains. So if you go to the culotte approach, so we had 6.7 TL target lesion failure at 1 year. And I show you now just 2 patients from the study, and this is ABC MAIN study patients now treated with TAP, young patients. You see, this is this left main. There was no question, and patients was randomized to single stenting, and the right coronary artery was okay. So here was very clear a message to go with predilatation and stenting from main branch, left main to LAD, kissing with the circ. Then there was significant problem here with dissection in the LCX ostium. So the next step will be to go with TAP. And I think if you're skilled in this approach and avoid long protrusion or avoid gap, so you can manage this very nicely. What is really very, very important to perform final kissing with 1-to-1 sized non-compliant balloons, what was done and with pot. And this is now a case which is, I think, with according acute result, very nice performance with good results. So this patient came, this is final result, and this patient came after 6 months, and you see this is of course a short-term follow-up by a very nice result for this double stenting. And this is now another patient with from ABC MAIN study with this difficult anatomy, and definitely Medina 111, but very short lesion in the circ. And here we were happy to manage this case with one stent pot, kissing, final pot. And I think we could really, I was surprised that the result was good. We managed LAD additionally with 2 stents. And finally, this patient could go home with quite good result. This is now just shown. Left main diagonal branch circ nicely open, and so we let it. We didn't treat anymore the circ, and this is 6 months later. I think really very good result for this circ, which was treated with kissing balloon dilatation. And just show you now this case, because I know there is a surgery professor from Oxford, Professor Agat with us, and I show you this case. This is a 58 years old patient with CABG history, 1 year back, still normal LV function, and he got arterial grafts of pump. So there was a trifurcation, really significant left main lesion, subtotal LAD, problem with LCX in this huge marginal branch or intermediate branch. And if you see now, you see only some bridges which are open. And yeah, the question is what to do with these patients. You see in this projection definitely a huge problem for the patients, but also for interventional cardiologists. The question is to send the patients back to the surgery to give them venous grafts, or to try to go with PCI. And I think this is really very important. If you go to the center, this is the right, which is still okay, and this is thoracica, arteria thoracica, and this is here occlusion. There was a problem here, and patients had for longer time symptoms, and now with aggravation of this symptom. So the idea was to wire intermediate branch, to wire LAD, to perform IVUS if possible, to stent LAD, and to mid-part LAD, and to perform dicky crush for intermediate branch and LAD. And again, IVUS evaluation and maybe PCI for diagonal branch. So you can see between, after pre-dilatation, we had this ECG, and the patient was not really fit. So we have to give some noradrenaline, atropine, etc. And so I was really under pressure to work very fast to rescue this patient. What we have done, we pre-dilate here this area, but LAD, but the patient was even more unstable, so it was really needed to go ahead. And I also wanted to be sure I can manage here this intermediate branch, because on this intermediate branch there was some bridge to distal circ. And finally, we could manage this case with dicky crush, final pot. It was here 4.5 stent and 5.0 onyx stent in proximal left main. And what we have done, we had here nicely open LAD, we have nicely open intermediate branch, and over this bridge, there is very nice connection to the distal circ. And what we have done, additionally, is a tap procedure for this diagonal branch, because there was no really good flow over this grafts bridges. So we put it one more stent to this large diagonal branch. And finally, in IVUS, it was really nicely shown, a good bifurcation area and perfect open distal left main. So this patient will come for re-entry in 6 months. Thank you so much.